Welcome to the Deep Dive, the show where we really try to extract the most impactful knowledge from complex medical literature. Today, we're undertaking a deep dive into the evolving strategies around lymph node dissection in managing gynecologic cancers. This is such a pivotal area, you know. Ongoing research is constantly refining how we think about its role, diagnostic, prognostic, therapeutic, and of course, balancing that against the risks involved. Our mission for this deep dive is pretty clear. We want to unpack the latest findings on complication rates, identify those key prognostic factors, explore newer metrics like the lymph node ratio, look at the nuances of lymphadenectomy across different cancers and stages, and maybe even touch on some exciting new surgical techniques. Really, the goal is to equip you with essential insights from these recent studies, helping you stay right at the forefront of patient care. Okay, let's unpack this. For experienced surgeons like you, the decision-making around lymphadenectomy, it's always highly individualized, isn't it? So what are the new data points shaping these critical decisions, especially when we think about patient safety and long-term outcomes?
Exactly, and that's a great place to begin. There's a significant retrospective study, Samathong et al. From 2024. They looked at nearly 400 patients across cervical, endometrial, and ovarian cancers. And it really gives us a detailed view of the complication landscape following pelvic and periaortic lymphadenectomy. What they reported was an overall complication rate of 42.4%.
42%, that's quite a number.
It really is. Nearly 1 in 2 patients having some kind of complication. That's something we absolutely have to factor into patient counseling, you know. And breaking that down, 26.1% were intraoperative. Then you had 11.0% acute post-op, so within about 29 days. And 14.0% were longer-term issues, showing up after that 30-day mark.
That 42.4% figure, it really does demand attention, especially when we're preparing patients. What did the study pinpoint as the biggest drivers for these complications? What factors should we be most vigilant about?
Yeah, they identified some strong independent predictors for overall complications, performing a laparotomy, for instance, that made complications over 5 times more likely. Huge difference.
Yeah.
And the presence of positive lymph nodes also more than doubled the risk. Operative times exceeding 4 hours also significantly increased the likelihood.
Okay.
And when they looked specifically at intraoperative complications, age over 60 also popped up as a significant predictor alongside those same things. Laparotomy, positive nodes, longer op times. It really reinforces that, disease burden and surgical complexity are major flags for heightened risk.
Right. And what about those specific complications we often manage? Things like lymphocytosis or lymphedema. What were the reported rates there, and how are they typically handled in this group?
Good question. Symptomatic lymphocyl was seen in 6.0% of patients, mostly a long-term issue. The good news there, thankfully, was that most cases showed spontaneous regression, often a relief for patients.
Hmm.
Lymphedema, another long-term worry, occurred in 2.0%. Again, typically mild symptoms managed conservatively self-bandaging physical therapy. Now, if we look at major complications, grade 3 to 5 using CDCAE version 5, the rate was 13.5% for the whole cohort. And VTE, venous thromboembolism, was actually quite low in the acute period, 0.8%. But interestingly, it rose to 3.0% in the long term. That's worth noting.
So we're seeing a noticeable incidence, even if the severe ones are less frequent. But the critical question for us and for our patients always comes back to survival, doesn't it? How did having a complication impact survival rates in this study?
Yeah, this is where it gets quite nuanced. Patients who had at least one complication did have a significantly lower 5-year survival rate, 92.31% versus 97.39% for those without.
Okay.
However, and this is key, the subgroup analysis showed something important. Among patients with metastatic lymph nodes, there was actually no significant survival difference whether they had complications or not.
Really?
Yes. But, and here's the flip side, for patients without metastatic lymph nodes, those who did experience complications had a significantly lower survival rate compared to those who were complication-free.
Huh? That's a fascinating distinction. It suggests that, well, complications are always bad, but maybe their impact on long-term survival depends quite a bit on the underlying disease burden.
It certainly seems that way. It adds a layer of complexity beyond just, complication. Yes or no?
Right. It sounds like a deeper layer there.
It does. And this idea of navigating risk and precision, it leads us nicely into another long-standing clinical question. For locally advanced cervical cancer, should we be doing lymph node dissection before the initial treatment, or does it just add risk without enough benefit? A recent meta-analysis by Zhang et al., also 2024, gives us some, pretty surprising insights here.
Oh, this debate. It's been going on for years in our field, hasn't it? Strong opinions both ways. Many of us have likely wrestled with this exact question in practice. So what did this latest meta-analysis actually find? Did it settle the score on pre-treatment LND and overall survival?
Well, surprisingly, no survival benefit. The meta-analysis found that lymph node dissection before initial treatment did not significantly impact overall survival. No meaningful difference compared to just going straight to concurrent radiotherapy.
No difference in survival.
Right. And crucially, it also found that pretreatment L&D did not increase postoperative complications or cause delays in starting radiotherapy. That really challenges some of the, let's say, conventional wisdom, suggesting that from a pure survival perspective, adding L&D upfront might not give that immediate advantage.
That is a powerful finding, especially given how much it's been debated. So if immediate overall survival isn't the main driver for pretreatment LND, what's its primary value then? Is it all about getting that precise information for planning what comes next?
Exactly. That seems to be the key takeaway. The meta-analysis highlighted more subtle but still very valuable benefits for treatment planning. Removing larger lymph nodes, they defined that as over 2 centimeters seemed to help define the radiation field more precisely, and that could potentially decrease radiotherapy-related complications down the line.
Okay, better targeting.
Precisely. And furthermore, doing the L&D first allows for actual pathological evaluation of that lymph node tissue. That significantly improves diagnostic accuracy by maybe 20 to 40% compared to just relying on PTCT imaging alone. So, yeah, it's about validating what the scans show and really refining the therapeutic approach based on pathology.
And how does the surgical approach itself play into this? We've seen such a huge shift towards minimally invasive techniques everywhere.
Indeed. And the study briefly touched on that again. It reiterated that the surgical technique really influences complication rates. Laparoscopic surgery consistently shows significantly lower rates, maybe 1.6% to 7%. That's compared to open surgery, where rates could be as high as 34% when followed by radiation. It just underscores, again, how we operate impacts patient morbidity quite significantly.
Absolutely. Okay, let's shift gears a bit now to a metric that seems to be gaining a lot of traction, the lymph node ratio, or LNR. This is pitched as a more refined way to look at disease burden, moving beyond just counting positive nodes, right?
That's exactly right. LNR, it's the ratio of positive nodes to the total number resected. As Chen et al. Presented in a big 2024 meta-analysis, the idea is it's a potentially more accurate representation of metastatic status. Why? Because it's less influenced by, say, individual surgical technique, how many nodes one surgeon takes versus another, or even the completeness of the pathology exam. It's an attempt to standardize the prognostic value you get from lymph node assessment. A significant step, potentially.
And this meta-analysis was huge, wasn't it? 34 studies, over 23,000 cases. What did it reveal about LNR's link to prognosis across different gynecologic cancers?
The findings were remarkably consistent and pretty compelling. A higher LNR was significantly associated with worse overall survival. The hazard ratio suggested more than doubling the risk.
Doubling, wow.
Yeah, and it also predicted worse progression-free survival and disease-free survival. Seeing that consistency across different survival metrics and across different cancer types within the analysis really underscores its potential prognostic power.
That is a strong signal, no doubt. But with meta-analyses, especially covering diverse studies in cancers, you sometimes see variability. Did the authors find any specific cancer types where LNR was maybe even more impactful, or perhaps less so?
They did break that down, yes. While it was broadly prognostic, the magnitude of the effect did vary. For overall survival, the pooled hazard ratios for a higher LNR were particularly striking for vulvar cancer. There, it indicated an over 8-fold increased risk.
Eightfold.
Massive. For cervical, ovarian, and endometrial cancers, the risk was still very significant, roughly a 2 to 2.5-fold increase. So it highlights that while LNR seems broadly valuable, its prognostic weight can differ quite meaningfully depending on the specific malignancy you're dealing with.
This really raises an important question for our clinical algorithms, doesn't it? If a simple ratio can give such a consistent, powerful prognostic signal across these diverse cancers, how might we integrate this? How could it refine patient management or counseling? It feels like it could play a big role in future staging or deciding on adjuvant therapy.
Absolutely. The implications for future staging systems are potentially quite significant. LNR offers a more unified and arguably more robust measure than just node count or FIGO stage alone in some cases. It could definitely help guide adjuvant therapy choices, especially where previous studies using different staging schemes might have given conflicting results. It provides a perhaps more precise lens for risk assessment.
All right, let's turn our focus now to early-stage epithelial ovarian cancer. This is another area where the role of extensive lymphadenectomy has been, well, debated pretty hotly for years. The ILAC study, a large retrospective multi-center effort by Yang et al. From
Mm.
2024, offers some compelling data here. What did they find regarding overall survival in these early-stage patients?
Right. The ILAC study focused specifically on clinically early stage EOC. And the top line finding, no significant difference in overall 5-year disease-free survival between patients who had a lymphadenectomy and those who didn't.
No difference in DFS.
Correct. And similarly, no significant difference in 5-year overall survival either. Plus, their multivariable analysis confirmed it. Lymphadenectomy was not an independent prognostic factor for either DFS or OS in this overall early stage EOC group.
Okay, that sounds like a pretty strong argument against doing routine lymphadenectomy in early-stage EOC then. But, as we always say, the devil's often in the details or maybe in the subgroups here. Were there specific patient groups where L&D did seem to make a difference?
Ah, yes. This is where the study gets particularly insightful and clinically relevant. While overall there wasn't a benefit, for patients specifically with serous histology, the lymphadenectomy group showed significantly higher 5-year DFS rates. The adjusted hazard ratio was 0.281, basically cutting the risk of progression by more than two-thirds.
Wow, that's a big difference for serous types.
It is. And lymphadenectomy was also associated with longer DFS in patients age 65 years or older. And another key finding, for patients who are not receiving adjuvant chemotherapy, the L&D group had significantly better 5-year DFS. The author specifically pointed out that this effect was much smaller or perhaps non-existent when adjuvant chemo was given.
So it's really not a blanket recommendation at all. It's highly targeted, emphasizing precision, isn't it? What about the trade-offs, though? Lymphadenectomy isn't exactly a benign procedure. What about the perioperative risks?
You're absolutely right to ask that. The study confirmed the expected trade-offs. L&D was associated with longer median operative times 200 minutes versus 135, higher median estimated blood loss 400 mLs versus 200 mLs, and, importantly, a higher rate of perioperative adverse events, 12.1% versus just 3.0% in the group without L&D.
Right. So putting it all together, what's the take-home message here? It feels like a definite nudge away from universal L&D towards something much more tailored, especially in early EOC. It's about weighing that diagnostic yield against the real perioperative risks, and maybe reserving L&D for those specific scenarios like serious histology or maybe older patients, where the benefit seems clearer.
Precisely. That's exactly what the author suggests. L&D should be considered selectively. Primarily as a diagnostic tool, not a blanket therapeutic one, especially when you're not yet sure if adjuvant chemotherapy is needed. It really allows for a more individualized treatment plan based on specific patient factors and the disease characteristics.
Okay, now for something really at the cutting edge, a technique that's pushing the boundaries of minimally invasive surgery. Venote's retroperitoneal sentinel lymph node dissection for endometrial cancer staging. Bakelent et al. Detailed this in a 2024 paper. This sounds incredibly promising for patient comfort and recovery. Tell us about the key advantages they're seeing.
Right, Venote's vaginal natural orifice transluminal endoscopic surgery. It's a truly innovative approach. The primary advantage, minimally invasive access through the vagina. So no abdominal incisions, no visible scars.
That alone is a big plus for patients.
Huge. And it's particularly beneficial potentially for patients who might struggle with the Trendelenburg position you often need in laparoscopy, like obese patients. Venotes doesn't require it. That offers real anesthetic advantages. It also follows the natural lymph node path, caudal to cranial, which might theoretically reduce the risk of missing sentinel nodes. And the early data on recovery looks good. Shorter hospital stays 30% discharged same day, median of 2 days for others, and really low median pain scores, like 1 out of 10 at 24 hours post-op.
That is an impressive list of potential benefits. How feasible is it proving in practice? And what about detection rates compared to our established techniques, laparoscopic or robotic?
Well, the prospective multicenter case series they reported, with 64 women, it showed impressive feasibility. They identified bilateral sentinel nodes in a high 97% of cases. That's right up there, highly comparable to established lap and robotic techniques.
97%. That's excellent.
Yeah. Median operative time was efficient, 126 minutes. Median estimated blood loss, just 80 millibeld. And they did find positive sentinel nodes in 6%, 3 cases of isolated tumor cells, 1 macrometastasis, so it is showing diagnostic utility.
That's a great detection rate for a technique that's still relatively new. What about the learning curve and the complication profile? Any initial concerns we should be aware of with this?
Yeah, definitely promising, but it's important to look at the early complication profile and acknowledge the learning curve. Absolutely. Overall, they reported 10 perioperative or short-term complications in this initial series. For instance, bladder injury occurred in 3 cases. That's an incidence of 5%.
Go 5%.
Now, they were all managed successfully, conservative or surgical repair, full recovery. But the authors are upfront that this initial rate is higher than what we typically see with, say, standard laparoscopic hysterectomy rates overall.
Right.
But they attribute this to the developmental phase and the learning curve associated with mastering any new technique. The expectation is this will improve over time with more experience. There was one case needing reintervention for bleeding and one conversion to laparoscopy, also for bleeding, but notably, no conversions all the way to laparotomy.
Okay, so still very early days, but the potential seems significant, especially maybe for obese patients where traditional approaches can be tougher. It really underscores that continuous innovation happening in surgical oncology, doesn't it? Always trying to balance efficacy with reduced invasiveness. It's exciting to see how these techniques evolve and, hopefully, become even safer.
It truly is. It pushes the boundaries of what we can offer, prioritizing the patient's experience and recovery without ideally compromising the oncologic principles. And that's something we should all be watching closely.
So we've really navigated some complex terrain today around lymph node dissection in GYN cancers. We started with those broad complication analyses, the factors predicting them, then dove into specific considerations for cervical and ovarian cancer, explored the prognostic power of LNR, and finished with the exciting potential of V nodes.
Yeah, and I think the common thread, really, across all these different studies is this undeniable shift, a shift towards increasingly personalized, more precise surgical strategies. We're moving away from the one-size-fits-all approach. The data is constantly nudging us, pushing us to ask, is this specific intervention necessary for this particular patient? What are the unique risks for her? And can a refined metric like LNR give us better guidance for her specific case?
And thinking ahead, as technology keeps advancing and our understanding of the underlying biology deepens, how will these insights change things? Not just refining what we resect, but maybe fundamentally reshaping how we even define optimal surgical staging and how we integrate it with systemic therapies for each unique patient. It leaves us with a lot to think about. We really encourage you to reflect on how these evolving insights might challenge or perhaps confirm your own current clinical practices and what new questions this sparks for your ongoing learning. Thank you for joining us for this deep dive.